also a reviewer for many peer-reviewed journals. She's the recipient of more than 8 million in competitive funding. Her main area of research interest is in the untangling of perioperative neurocognitive disorders, including biomarker and intervention strategies to reduce or prevent these in older individuals. So I'd like to welcome Dr. Everett. Thank her for joining us today, and we're looking forward to your talk. So the floor is yours.
Thank you so much. Let me just try and share my screen and start my slideshow. Okay, can everyone see and hear? Okay. Yeah.
You could be a little louder. It's a little soft, but I can see the screen.
I wonder where my volume is. Here we go. Oh, that's my speakers. That's not what I wanted. Here we go, microphone. It doesn't look like I can do anything about it. Oh.
That's a little bit better.
Is it? Maybe I'll just speak louder.
That's better.
Yeah, better.
If you click the microphone little the thing next to it, it gives you some options for how your microphone is coming, but it's sounding better.
Okay, all right. Let me know if it goes away and you're not hearing me. Okay, so I first want to say thank you very much to Dr. Ingrande for inviting me to give this lecture. I wish that we were in Washington face to face and I got to meet you all, but here we are anyway. So I'm going to talk about perioperative strategies to prevent postoperative delirium. So the outline of my talk looks long, but I'm sure I can fit it all in. So I'm going to just outline what postoperative delirium is and the impact that it has, the various guidelines that are around in the anaesthetic literature, preoperative, intraoperative and postoperative strategies that can reduce or prevent delirium, a little bit about biomarkers, and I want to cover some of the multi-component interventions, and I will be presenting some results of the balanced delirium sub-study, as Kate alluded to, and I'll also be talking about a large multi-component intervention study we're undertaking in Melbourne, and the summary. So first of all, just to highlight the fact that confusion and delirium are two different things. Delirium it may include confusion, but it has a number of features that really need to be addressed by doing a specific test. Just knowing that someone is confused is not a diagnosis of delirium. So delirium is fluctuating, it has an acute onset, it is associated with inattention and either altered consciousness or diagnosed or disorganized thinking. So this is basically the CAM, which is derived from the DSM. It's the most common tool used to assess for delirium. And as I said, feature one, acute onset and fluctuating course. And you can see on the slides, there's a bit of an example of how you would assess for that. Feature two, inattention. So in order for a patient to be diagnosed with delirium, they must have the first two features and either disorganized thinking or altered level of consciousness. So 1 and 2 and either 3 or 4. I won't talk about subsyndromal today at all, but just to point out that it is something that's thought to be an issue, and there is certainly quite a bit of research coming out to suggest that it may be associated with poor outcomes, just as a diagnosis of delirium is. So there are 3 subtypes of delirium: hyperactive delirium, which is something that you will know when you see it. The patients are agitated, pulling lines out. It's thought that this is probably the minority of cases of delirium. Hypoactive, the patients are very lethargic, they really aren't responding. They're the nurse's dream patients because they don't ask for anything. And then there's mixed, where patients may have both over a period of days. So how do we measure delirium? Well, I just put this up as just a very basic outline. There are many, many, many more delirium assessment tools than what I've put here, but these are the most commonly used. Just to highlight, the 4AT is a screening tool. It does not diagnose delirium, but it's in Australia becoming, and the UK, one of the key tools to screen for delirium in hospitals where that is becoming routine care. Obviously the gold standard is a psychiatric assessment or a geriatric assessment or a neurology assessment based on the DSM-5. But the CAM and the 3D CAM are tools which, with appropriate training, nurses or research staff can undertake the online training and become proficient with high sensitivity to use those tools. So what's the impact of delirium? This is some data from our group in Melbourne. So in the literature, about 10 to 65% of people undergoing anaesthesia and surgery who are over 65 years of age are likely or possibly will have an episode of delirium. In our patients in Melbourne, over the last few years, we have identified that, I do apologise, that following cardiac surgery, almost half of the patients experience an episode of delirium and a third of non-cardiac surgery patients. And as I said, with hypoactive delirium, about 75% of it goes undiagnosed because without actually testing everyone, you won't know they have it. Delirium in the elderly, this is some work from Sharon and Nui and Esther O. I just put this up to show you that in surgical patients, this is a review looking at the proximate incidence following cardiac, non-cardiac and orthopedics operations, which is very similar to what we have found in our work. And it's certainly in line with what's being published in the literature. Delirium is associated with significant harms. People who have an episode or more than one episode of delirium whilst they're in hospital are much more likely to die. They are much more likely to end up institutionalised, and they are much more likely to end up with dementia, long-term dementia and cognitive decline. They're at increased risk of falls, and if they're discharged home with delirium, they're at increased risk of being non-compliant with post-discharge instructions. This is some more work from Sharon Inouye, just showing you that the patients who had an episode of delirium or more than one episode during their hospitalisation kind of rebounded back, and we've seen that with a lot of cognitive work. They seem to have this rebound early on, but then by 3 years post-operatively, you can see that those with delirium have declined considerably greater than the patients who didn't experience delirium. This is the NISQIP. Now, I believe that there has been an update, but I searched and searched and could not find any update on that website that included cognitive health. So I just wanted to point out that the interesting thing about this is that we put in all of this information about our patients and get, your risk relative to what the average risk is, but we don't actually talk about delirium and what the risk of patient getting delirium is. We really need to be taking account of the patient preoperatively and looking at their dementia risk, because not only is that the most common complication following anaesthesia and surgery, but it increases the risk of all those other things as well. So having an episode of delirium actually changes what your risk up there would be for, say, any complication. So we think this is a really important thing, and we think that it should be part of that calculator. Just going on to financial and social costs of delirium. This is some work from Gideon Kaplan. He's a geriatrician in New South Wales in Australia. And he's done a couple of studies looking at the cost of delirium on the healthcare system. You can see these are population studies, not surgical patients. So in fact, surgical patients would definitely cost more because of the in-hospital situation. And he's calculated about 4.2 billion Australian dollars per year. And not only that, but having an episode of delirium leading to dementia looks like it reflects that about 10% of dementia in the community is related to a prior episode of delirium. So if we can reduce delirium, it's quite likely that we can reduce the incidence of dementia in the population at large. I won't go into that table, just to show you that, you know, we're talking about millions and millions of dollars, and even just one patient is going to cost an extra $66,000 due to an episode of delirium. Okay, so we should have some guidelines about how to manage these patients. And this is just a table of the current guidelines for cognitive care management, mostly in the last couple of years. I will go through some of them in a bit of detail, and you can obviously look those up. They vary in what they address in terms of delirium or dementia or both. So they're not all consistent. This is some work from the American Society of Anesthesiologists Brain Health Initiative. We had a summit in Washington in 2018, and really what came out of that was some interesting aspects that we need to be thinking about, and some interesting issues, particularly around the use of EEG and the fact that it doesn't seem to be at this point in time warranted to reduce delirium or have the ability to reduce delirium, but it kind of set the stage for where we are and where we need to go. This is some best practices from our perioperative neurotoxicity working group a number of years ago from Miles Berger, and just to highlight that you'll see the bottom there, EEG-based intraoperative brain monitoring to titrate anaesthetic administration. That was based on the fact that although there's little evidence to suggest that EEG-based monitoring can reduce delirium or postoperative delirium, the group decided that it was probably something that should be done with respect to titrating anaesthetic anyway. This is some work from the Association of Anaesthetists in Great Britain and Ireland, and that it is more to do with dementia, but it is a fantastic piece of work if you're interested in reading it. It's long, it goes through some really good information about caring for patients with dementia in the perioperative period. And also one of my colleagues and I wrote an editorial about that. The other groups that are thinking that they should be helping people avoid delirium, one of the groups is the patient safety movement. And there was a large group of us over the last couple of years who put together an actionable patient safety solution for postoperative delirium in older adults. You can go online and have a look at that. It was principally to do with how hospitals should be dealing with patients with delirium, what protocols and policies they should have in place, what education should go out to patients and their families, and contacts for follow-up if patients needed or staff needed. The Global Council on Brain Health has been very involved with the ASA Brain Health Initiative. And in addition to that, there was a group of 18 experts, which I was one of, and we met in Boston last year, back in the days of being able to travel. And they have put out this in March this year, Preserving Your Brain Health During Illness or Surgery. And this is designed as a report for consumers. Things for them to focus on, things for them to ask, because so many times patients don't know the right questions to ask. This is from the ASA Brain Health Initiative. We had a group of experts, 18 experts on this, and we put together a series of recommendations, and this is in press at the moment. And I just wanted to give a bit of a plug for the Alzheimer's Association, who run the iStart, which is the for research and involvement in any Alzheimer's research at all. They have a number of different professional interest areas, one of which is perioperative cognition and delirium. You can see the committee's names there. I just wanted to highlight this because it's worth joining if you're interested in this field of work. It's a great opportunity to develop collaborations with multidisciplinary teams. And we have sessions at the AAI. Put out quite a number of white papers. Sorry about that. So, what preoperative strategies can we implement to reduce delirium? First of all, preoperative cognitive assessment. Preoperative cognitive impairment is the strongest predictor of a patient experiencing postoperative delirium. Preoperative screening should be mandatory for anyone 65 years or more coming in for surgery. And this may allow us the opportunity to prevent delirium and further cognitive decline. And I'll talk more in a little while about other possibilities that could help us do that as well. Just to give you an idea of some screening tools, the MOCA, the MiniCog, the clock drawing test are very quick and simple. They don't need a lot of training, so they can be done by admitting staff. Just to highlight the fact that we really avoid the mini mental because it really only tells us when someone is really unwell or really cognitively declined, whereas the MOCA has much greater sensitivity for subtle impairments like mild cognitive impairment. It's important to ask for a subjective assessment. That often it precedes a decline, so it may be a harbinger for further decline, and maybe that someone is at risk. I just wanted to show you two clocks. The clock drawing test is really becoming, I mean, it's 50 or 60 years old, but it's becoming more and more useful because it's quick, easy to administer. There are now digital versions being tested, and you can see by these clocks that it gives you a stark reality straight away that there's something wrong. Together, screening for cognitive assessment preoperatively will allow us to follow appropriate pathways either preoperatively or during the postoperative period so that the referrals to appropriate multidisciplinary teams can be successfully made and undertaken whilst the patient's in hospital. Predisposing factors for delirium are, I've highlighted in pink the central column, which is for surgery. You can see that dementia, any sort of cognitive impairment, you're increasing by up to 4-fold. Any previous history of an episode of delirium, functional impairment, visual impairment, all of those things are likely to increase your risk of suffering from postoperative delirium. This is some work that we are trying to undertake in our hospital in Melbourne, trying to change the way the pre-assessment is done on a patient in the pre-admission clinic. So instead of just asking the routine health questions, we're suggesting that we ask those important questions. Do you have cognitive impairment? What's your level of independent living or frailty? And have you had confusion or delirium in the past? All of those answers are no, go ahead. If the answer to one of those is yes, we need to probably think about doing a screening, something a bit more than a plain screening test. with questions. So do they have a memory complaint? Do a 4AT or a MOCA or a mini-cog? And what's the level of surgery risk that they're undergoing? If it's no, then they should go along the same pathway, but there should be handover that this person might be at risk. And then if there's yes in those columns, then they should go on and have a proper screening test that will give us an indication of their level of decline. They should be put on a high-risk care pathway. Follow-up needs to be part of handover for staff and carers. And then if the patient is impaired in the post-operative period, then they probably need to have an in-hospital referral and a referral post-discharge. Intraoperative strategies. There's no evidence for specific anaesthetic agents that make a difference to the incidence of delirium at this point in time. There's no difference in the incidence of delirium between regional anaesthesia and general anaesthesia. It does look like the severity of surgery might increase the risk of delirium, because we do see a much greater incidence in patients having cardiac surgery, for example, than in patients having hip joint replacement surgery. We should avoid intraoperative hypotension, and that has not been directly associated with delirium, but it's obviously part of a healthy anaesthetic plan. There's been some work on ketamine, which I'll talk about in a moment, and dexmedetomidine has been shown to be effective in intensive care delirium, but doesn't look like intraoperative administration makes any difference to ward, the incidence of delirium on the ward. So this is some work looking at hypertension and delirium by Dan Sessler's group, and they found that there was an association between low MAP, so MAP, the time spent with the blood pressure of less than 65 was associated with an increased risk of delirium. There were 1,000 patients. They had a 35% incidence of postoperative delirium, which is actually quite low for intensive care, which suggests there might have been an ICU CAM assessment bias, such that patients who were agitated were much more likely to get an assessment than patients who, were quiet and calm. I've already said low incidence. So the points for consideration are it's retrospective, which is why the issue with the ICU CAM perhaps having a bias, because people are much more likely to undertake an assessment on a patient who's obviously got symptoms rather than a patient who doesn't have obvious symptoms. Okay. This is some work from Mike Abadan's group looking at intraoperative ketamine. There has been a couple of studies on intraoperative ketamine. I won't go through them all, but this is the most recent and the most robust so far. There were 1,360 patients. They were in 3 groups, placebo versus 0.5 milligrams per kilogram or 1 milligram per kilogram bolus at induction of anaesthesia. And they saw an incidence of delirium of 19% versus 20%, so no difference. The only points I will point out that need to be considered: hallucinations were greater in the higher dose group. Whether that's hallucinations that are part of delirium or whether that's some kind of different brain fog causing those hallucinations is unclear what the mechanism is. It could be a false negative due to the low incidence of delirium. Also, if mechanism is via analgesia, increased doses or prolonged infusion may in fact help. And so we are part of a study called the ROCKET study, which is a multi-centre international study. And that study is looking at ketamine for chronic pain. and we are undertaking a sub-study looking at delirium. So that will give us some really good information about the use of a low-dose infusion of ketamine over a longer period of time. This is a meta-analysis. I honestly didn't think there were enough ketamine studies to do a meta-analysis, but there you go. So this study had 6 RCTs, and that totaled 928 patients. Of the 6 RCTs, 3 investigated postoperative delirium, 2 investigated postoperative cognitive dysfunction, and 1 investigated both. You can see that there's no effect, but they did also find that there was low quality evidence in some of the studies. So overall, the quality of evidence is low. What about anaesthetic depth? So back to the Engagers trial by Mike Avidan's group, 1,232 patients, 60 years or older, undergoing major surgery. Some were cardiac, some were not. And again, a very similar incidence of delirium in the 2 groups, 26% versus 23%. So the interesting thing about this study is that both groups had burst suppression, both groups had time with BIS less than 40, neither group was hypotensive, both groups were part of a care pathway. So in the hospital where this study was undertaken, they already have in place a care pathway for older patients to avoid delirium, which may account for the low incidence, but it also may have created a bias in the study. And also, as with most of the EEG studies, it's BIS versus standard care. So you're just not getting that separation between the groups. And obviously the results did not support the use of EEG guided anaesthesia to reduce postoperative delirium. This is some work from the Perioperative Quality Initiative Joint Consensus. And again, they are confirming from their reading of the literature that there is insufficient evidence to recommend use of EEG for preventing postoperative delirium, neurocognitive disorder, or postoperative cognitive decline. Anaesthetic depth and complications after major surgery. This is the study that Kate spoke about just before. The BALANCE study was a study investigating two targeted BIS, one of 50 and one of 35. And so we undertook a sub-study of this BALANCE study looking at delirium. We felt that it was a perfect opportunity to get results about delirium using processed EEG with 2 targeted anaesthetics so that we knew that we were getting separation between the groups, or we hoped. So the hypothesis was that patients undergoing major surgery randomised to receive a high BIS, so low dose anaesthesia, will experience a reduced incidence of delirium and maintain levels of postoperative cognitive function compared to patients randomised to a low BIS, high dose anaesthesia. The eligibility was all participants enrolled in the balanced anaesthesia study, and they were all at the sites which took part in this, and they were invited to participate after commencement of the sub-study. So the sub-study started after the balanced study started. We did the 3D CAM, which is a 3-minute diagnostic set of questions based on the confusion assessment method, twice daily for 5 days or until discharge. If the patient was in the intensive care unit, we used the CAM ICU. We administered the mini mental state examination at baseline and hospital discharge, and the abbreviated mental test score at 30 days and 12 months because we were restricted to phone follow-up. We ended up with 499 patients in our analysis. They came from 8 sites across 4 countries. They were all 60 years or older, undergoing major surgery, and as I've said, they were randomised to a high bis or a low bis anaesthesia. So the sites were Australia, Hong Kong, China, and the USA. These are the basic demographic results. You can see that there's no difference between the two groups. And these are the intention to treat results. And you can see that the incidence of delirium in the low bis group, so the high bis group, the light anaesthesia was 29% compared with 38% in the deep anaesthesia group. And I can't see. So, and you can see that the odds ratio for that is significant and suggests that lighter anaesthesia is likely to reduce the incidence of postoperative delirium. We feel really excited about these results because it's really the first study where there has been good separation between the groups rather than one bis target being compared with routine or standard care. In addition, we found that at 30 days, sorry, at 1 year, at 30 days, like I said with the Sharon Anui slide, people seem to pick up. So these people who've declined at 1 year have picked up in the earlier period. So you can see that at 30 days, there's no difference in cognitive impairment, in the incidence of cognitive impairment between the two groups. But by the time we get to 1 year, 6% in the light anaesthesia group compared with 19% in the deep anaesthesia group have scores on the abbreviated mental test score that suggest that they are impaired. So what about postoperative strategies? So in PACU delirium is a really interesting thing because if you assessed a patient, any age, at exactly the right moment of their emergence, they would meet delirium. It's just one of those things. So it is difficult to know whether we need to have a lucid period before we start calling it postoperative delirium after the PACU stay, or if we should just look at PACU as a different environment for delirium. Although we do know that if you have an episode of delirium in PACU, you are at increased risk of having another episode on the ward. Nevertheless, in PACU, there could be lots of reasons why a patient is having an episode of delirium. So look for the cause, assess consciousness, make sure there's no residual sedative drug effects and perhaps treat them if there is. Make sure pain is under control. Any other irritants that could be causing irritation to the patient and causing them to be agitated. Antipsychotics I won't go into, and we'll cover that, I'm sure, much more. Just to say that there is very little evidence, if any, that giving antipsychotics helps an episode of delirium. It should only be used in a situation where either the patient or staff are at risk. Risk factors for delirium. So these are just a long list of things that could happen in the post-operative period that could increase a patient's risk of having an episode of delirium. This is quite a good paper by Sharon Inouye, and that's worth having a look at. You can see down here aortic aneurysm surgery. They're putting that at an 8-fold increase in the risk of delirium. So I spoke about this before. This is part of our cognitive care standards in Australia. What I wanted to discuss here is the things that we can do in the postoperative period that have shown they can reduce delirium incidence and improve recovery. So these are based on Sharon Inouye's health guidelines that you can find them on the AGS website. Basically, they're things that family could do just as well as staff. So it comes back to the possibility of educating patients as well as their families. So review medications, avoid polypharmacy, make sure the patient is eating if possible and drinking. Early mobilisation is definitely one of the key things here. Making sure pain's under control, reorienting and reassuring. So having a clock in the room with the day and the date. Activities for stimulating cognition. So having some crossword books or Sudoku books or something that they like doing. Making sure they can get enough sleep, which obviously in hospital is a really difficult thing, particularly in intensive care. And make sure the patients have their hearing and visual aids. You can imagine how confusing it is if you can't see properly and you can't hear properly and you're being moved from one place to the other and you don't know who your neighbours are. Those things are really, really important, and we have seen these will reduce delirium from occurring. So I just wanted to talk a little bit about biomarkers. The main reason is that I'll give you a bit of a background with regard to the mechanisms. Our reason for being interested in biomarkers is multiple. Firstly, because it may give us an opportunity to understand the pathophysiology of delirium in a much clearer way. Additionally, it might give us the opportunity to do a blood test preoperatively and very easily identify at-risk patients. So this is just a very busy slide looking at the biomarkers that are associated with neurodegeneration. I won't go into a lot of detail. This is some work on anaesthesia and inflammation, speaking of biomarkers. This is actually from Niccolo Turando a few years ago, but he very convincingly showed in mice that in mice who had tibial surgery and anaesthesia, they got a pronounced inflammatory response with TNF-alpha. In mice who underwent anaesthesia but no surgery, there was no response, no inflammatory response at all, leading us to think that there must be something happening with respect to the surgery. So this is our current theory, the possible pathophysiology of cognitive disorders, including delirium postoperatively. Surgery induces a peripheral inflammation in conjunction with a leaky blood-brain barrier that could be due to age, it could be due to systemic illness, it could be due to drugs that are being used, leads on to neuroinflammation. We think that what happens after that is that there's a release of neuronal damage biomarkers. So there's neuronal damage and a release of markers that tell us that that has happened. And then following that, the neuronal damage that's been caused by the inflammation goes on to give us delirium or perioperative neurocognitive disorders. And I'll talk a bit more about this neuronal damage in a moment. Right now, in fact. So neurofilament light, we're hoping might be brain troponin. It's a component of the axonal cytoskeleton, and it is associated with a number of neurodegenerative diseases. What has occurred over the last few years is that whilst these sorts of biomarkers used to be only able to be identified in cerebrospinal fluid because of the sensitivity of the assays that were available, there's now been a huge launch of the Simoa machines, the single molecule assays, and now we can sensitively identify these markers in blood. And in fact, one of the really great things about neurofilament light is that there's a really close correlation between CSF neurofilament light and blood neurofilament light. The correlation is, for our data, was about 0.9. So we're confident that this is coming from the brain and not from peripheral sources. Tau is a little bit more difficult to work with from that point of view, but we know, again, that it is associated with neurodegenerative disease. So we undertook this study a few years ago, It was a small study looking at a group of 30 people who came from a convenient sample of 2 studies where we had taken 5 sequential blood samples. They were an average of 69 years old. They were undergoing non-cardiac surgery. We assayed for neurofilament light and tau. And as I said, we took samples baseline, 3 minutes, 6 hours, 24 hours, and 48 hours. And what we found was that postoperative delirium was associated with higher levels of both tau and neurofilament light at 48 hours, and that postoperative cognitive decline at 3 months was associated with higher levels of neurofilament light and tau at 48 hours. What we're hopeful is that with more numbers and larger studies moving into this biomarker world, we'll be able to identify not just that the rise is associated with those at risk, but that preoperatively we can identify from a blood sample who's at risk. This is some work from Rob Sanders, and they also looked at neurofilament light and postoperative delirium. They studied 114 people aged 71 years on average. They looked at neurofilament light and inflammatory cytokines. They had an incidence of delirium of 36%, which is about what you would expect. And they identified a dose-dependent association between increased neurofilament light and delirium severity. So there's a number of groups looking at this, and we are generating some really interesting work in a really short space of time, and hopefully over the next couple of years we'll have some sort of definitive information about how we can identify patients and what the level of neuronal damage is, and longer term studies to look at whether the neuronal damage actually improves. So all of those studies have looked at anaesthesia and surgery. Rightly so, because undergoing surgery without anaesthesia or anaesthesia without surgery is not ethical. However, Stacey Diener and her group have recently published the TORI study, and what they looked at was human plasma biomarker responses in patients undergoing an MRI. So they had an anaesthetic for an MRI with no surgical intervention. The group were quite young, 40 to 80. They had a propofol induction and sevoflurane for the MRI. They assayed for tau, NFL, GFAP, which all decreased rather than what you saw in the other studies where we had surgery as well, they all increased. And interleukin-6 did increase, but it didn't look like it was something that would be clinically relevant. TNF-alpha and CRP remained unchanged. It's a really, really important piece of work. And we need to find ways of doing more bigger studies like this. There are limitations. As I said, it was a young group, not necessarily vulnerable to cognitive decline or biomarker responses to surgery. There was some difficulty with the sample analysis. They were assayed at 2 different labs. They did have a freezer thaw for a number of samples, but they have provided some really good data in the review process to show that that was unlikely to have any bias. It's unclear what exactly the duration of anaesthesia was. It's unclear what the time to the 5-hour blood draw was. So whether that's comparable to what's been done in other studies like ours or not, we're not sure. And as I said, propofol induction. So in conclusion, SIVO without surgery did not evoke a clinically relevant inflammatory response or detectable neuronal injury. Okay, multi-component interventions. This is a study from last year looking at multi-component non-pharmacological delirium interventions for older patients. These are population patients, not surgical patients. They looked at 25 studies. The studies ranged in sample size from 30 to nearly 20,000. They had between 5 and 18 intervention components in those studies. The average was 11. They found it difficult to draw conclusions, as with most cognitive studies, because of the significant heterogeneity between the way the data is assessed, the way the outcomes are described and defined. It's quite a problem. 2/3 of the studies reported that delirium incidence was reduced with non-pharmacological multi-component interventions. So that's positive. This study, sorry for the small print, was published this year, looking at, again, postoperative delirium, perioperative assessment and management. And you can see on the left-hand side, just a schema for assessing preoperative risk, risk reduction, recognition and management. So making sure we check that patients have or do not have delirium by doing an assessment every shift, and then post-discharge care and specialist follow-up. They also found that non-pharmacological interventions were associated with a 45% reduction in delirium, which is amazing. The problem with most multi-component intervention studies, and this is one great example of this, is compliance. So this is again just published this year by Brian O'Gara. 45 patients, their age was 70, median of 70, mostly males. They were randomised to either receive the luminosity cognitive training or routine care. The compliance was between 6 and 39% for the tasks that the cognitive training group was supposed to undertake. And I think this highlights the major difficulty with multi-component interventions is monitoring the compliance is really difficult. And then trying to compare against a control group when you actually aren't getting separation is even more difficult. So not surprisingly, there was no statistical difference between the groups for postoperative delirium. So I just wanted to run through, this is a study that we are doing in Melbourne. This is a multi-component intervention study for delirium and long-term dementia. Unfortunately, due to the pandemic, we're on hold, but it's ready to go. And so this is an NHMRC funded study. We are going to enrol 692 patients, and we're calling it really brain ERAS. Basically, what we need to do is have a system that optimizes patients, not just during the hospitalisation, but preoperatively and postoperatively. And so from our point of view, brain ERAS extends a lot further than just the admission. I'm sorry this is so busy. This is our intervention flowchart, and just the take-home messages are simply that a patient who is randomised to control will just go through a normal hospital pathway. A patient who's randomised to the intervention will have education, pre-admission clinic, motivational interview, actigraphy, all of those help things that I talked about before, pardon me, will happen during their hospital stay, including physio. They'll be part of the APS. We'll have cognitive stimulation for them, sensory aids. So they'll get all of that intervention in the post-operative period. And then post-discharge, they will take home books to keep records of their exercise and their healthy eating, and I'll show you an example in a minute. And we're going to send SMS reminders. We're going to have group education sessions and monitor their exercise with actigraphy, because we think that's really the only way we're going to get to know how compliant the intervention patients are with the actual intervention. So this is what we want patients to see preoperatively. Educate them, educate their family, how to prevent delirium, ways that you can optimize yourself and your lifestyle factors preoperatively. And then postoperatively, again, they'll be given information about good eating, they'll be given an exercise plan, they'll be encouraged to undertake social activities as soon as they feel well enough to do so. And as I said, we're going to have classes that people can opt into if they want to come and learn or do some exercise or socialise, a whole variety of things that will be optional as well as the required part of the study. These are our outcomes. I'm sorry this is so busy, but basically our primary outcome is perioperative neurocognitive disorders to 3 months. So delirium, delayed neurocognitive recovery at 30 days, or neurocognitive disorder at 3 months. Secondary outcomes, you can see there's a whole lot of those, which will include instrumental activities of daily living, disability, readmissions, frailty, depression, quality of life, and cognition, obviously, out to 12 months. Just quickly on the discharge planning, which I did mention briefly before. So once the patient is going home, we need to remember that that shouldn't be a complete separation or severance of care. We need to be involved with discharge destination planning, and that should involve family and friends, if possible, or caregivers, because the likelihood of compliance with postoperative orders is much greater if there are other family members or friends or caregivers who understand the information as well. And a really strong point, do not discharge home with delirium, which you probably all think is a silly thing to say, but in our work, hypoactive delirium patients are sent home all the time. Probably we had about 10% of our patients with hypoactive delirium were discharged, some of them to home alone, still with delirium. So that's something that I think we really need to be working on. And as I say, this is all related to their post-discharge compliance with medications and postoperative instructions, including rehabilitation. So in summary, postoperative delirium is common. Postoperative delirium has serious short and long-term poor outcomes. We need to be screening preoperatively, it's essential. We need to monitor and manage during the intra and or whole perioperative period. Biomarkers suggest inflammation and neuronal injury may play a role, and that's a really big area of research interest at the moment. Multi-component interventions may reduce or prevent delirium and ultimately should become part of routine care. Prevention will be based on identifying at-risk patients. We need to find the patients who are at risk preoperatively in order for us to intervene and avoid the outcome of delirium postoperatively. And targeting light anaesthesia is associated with a lower incidence of delirium compared with targeting deep anaesthesia. Thank you very much for your time.
Thank you, Dr. Everett. That was an excellent presentation. I'd like to open it up to the audience for any questions.
Yeah, Liz, that was fabulous. Particularly nice to hear that BIS makes a difference finally. Yeah, I don't recall you mentioning either benzodiazepines or gabapentins, which are, you know, common drugs, and gabapentin in particular is an ERAS commonly included in the multimodal analgesia that patients receive in the perioperative period for ERAS. And does multimodal analgesia make things better or worse when delirium is looked at as the outcome. But maybe just the benzos and gabapentin alone would be of interest.
So I don't know about multi-component pain control. I do know that unstable pain or pain that's out of control is definitely associated with an increased risk of delirium. With regard to the drugs, I didn't get into that because I think Anne, who's the next speaker, is going to cover that more. I will just mention something about benzos though, because my interpretation of the literature is that benzos shouldn't be used and are associated with a higher risk of delirium, whether in surgical patients or in patients in the community. But there is a study that has just started called the Be Free study. I don't know if anyone's familiar with it. And the Be Free study is actually looking at, it's a cluster randomized trial, and hospitals are, so they randomize 1 month to having basically targeting no intraoperative benzos in cardiac surgery patients, and then the next month, liberal benzos in the intraoperative period. So it sounds interesting, except I wouldn't have thought there was equipoise. But anyway, what I'm struggling with is that they're not taking into account any benzos preoperatively or any benzos postoperatively. So I'm struggling with how that's going to answer any question that could change clinical practice.
And the endpoint, presumably, is what, 48 hours, a month?
Well, that's a great question. I think it's 30 days.
Ah. Huh. Yeah. Does sound kind of silly.
Dr. Everett, we have a question from the audience. Dr. Billard's asking if you'd recommend canceling or postponing surgical patients if they're too high of a risk.
I think that is going to be the situation that we should get to eventually. I think that there has to be a risk-benefit ratio. So obviously, if it's an emergent surgery, then that's a kind of different thing. But if it's an elective surgery and the patient could be optimised by waiting a few weeks, like at our cancer hospital in Melbourne, patients who are unwell and unhealthy go through a 6-week surgical school of optimisation before they have their surgery. And I think it has to be part of the conversation. Your outcome could be much better if we did X, Y, and Z before you have the operation. The other thing is that there's a big push, if you like, for getting rid of futile surgery. So there's a geriatrician in the UK who has implemented a pre-screening for delirium risk at the first surgeon's visit, and they have reduced delirium significantly, and a lot of that has come because they've cancelled patients who they deemed the surgery to be futile.
Very good. I actually have one question myself. Going back to the biomarkers, did you notice a correlation between the level of increase in neurofilament light and/or tau and the severity of post-operative cognitive decline?
I haven't actually looked at the severity yet, but we do have the data to look at that.
I see. Very good. Are there any other questions from the audience?
Yeah, just Joe here. Very interesting talk. And going back to the biomarkers, do you have a sense, I mean, obviously a lot of complicated interplay here. To what extent inflammation in the brain is a symptom and the biomarkers are reflecting that versus it's that inflammation that's actually causing the delirium?
Who knows? I don't know. I don't know that we can answer that at this point in time. But you know, we have studied so many things with respect to well, more with respect to longer term cognition. And I guess also, you know, crossing over with Alzheimer's disease research, we know that inflammation has a significant role in neurodegenerative diseases. So I think that the most likely explanation is that it's the inflammation and then the neuronal damage. And that seems to be what happens with traumatic brain injury. So this work on neurofilament light has come really from the work that's been done in sports players on neurofilament light. So even a mild concussion will see these biomarkers increase, and they're increasing in levels that are similar to what we see in anaesthesia and surgery. I don't know that I've answered your question, I'm sorry.
Well, it sounds like there's not a clear answer. I'm
No.
just curious because by way of conflict of interest disclosure, I'm working on a drug that treats neuroinflammation, and this is an area that I haven't looked at yet, but it's something that piques my interest.
That sounds exciting.
We have time for one more question. That'll come from Dr. Mendel, who has his hand raised. So I'll allow him to answer the question, or ask the question, I should say.
Okay, I'm hoping I've solved my echo problem here. But so a number of years ago, I suggested to Rod Eckenhoff that I had this idea for letting people breathe subhypnotic concentrations of sevoflurane to induce mild perturbations at the time I was interested in postural stability, but I think you could do it with other endpoints as well. I'll see if that might be a useful way of detecting people who are at risk for perturbations and prolonged recovery. He, of course, responded in horror because he thought, you know, I wouldn't want to breathe sevoflurane if I didn't have to have a surgical procedure because it might cause me to make that transition into early Alzheimer's. And I'm just wondering about your thoughts about this. I mean, number one, do you think that there's a difference between subhypnotic concentrations of all agents, or do you think, you know, is there a threshold that you go above this threshold and you get neurocognitive decline, but below that, it probably doesn't matter that much?
It's a really interesting question. The delirium literature suggests that the dose is that it is a dose-dependent sort of result, and that may be in terms of episode, or it may be also in terms of severity of episode. But with the longer-term cognitive impairment, we don't see that. So one of the studies we did a number of years ago, we saw at 3 months postoperatively, there was no difference in the incidence of cognitive decline between patients who had cabbage surgery versus hip joints versus some light sedation for an angiography. So I think it's interesting that I think for some outcomes there may be a dose-dependent result, and for others perhaps not.
Okay.
Would you breathe the sevoflurane?
Maybe.
Okay.
All right, Dr. Everett, thank you so much for your presentation. It was outstanding. We'll go ahead and open the floor now to Dr. Donovan, who's going to